like us. There's a good scene in there about how doctors address each other. I'll show it to you. It's really funny.
Got better audience than we do for new conference.
Alrighty, we're going to go ahead and get started since we got to get out of here right at 3 o'clock. I'm Mohammed Solomon. I'm a second-year resident.
Hi, I'm Leonard Ferdman. I'm a first-year intern resident.
And this is Dr. Sarah Awesome. She is our, I think I can call you program director now. She's our program director. Unfortunately, Dr. Wright couldn't be here. He was so disappointed to miss, but he was really excited that Dr. Awesome could join us. And I'll do a little introduction on her and her background a little bit, and I'll let her talk about herself a little bit as well. But yeah, welcome to You and Your Health. Today we're going to be talking about coronary artery disease. And before we get on to that,
Stand by.
The hardest part of medicine is.
oh, there we go. All right, so a little bit about Dr. Awesome. She's actually from the area, from Farmington, Arkansas, and went to the University of Arkansas for Bachelor in Science in Biology. She's actually Iranian American and went to medical school at Ross University and did her training at UCLA, where she was actually chief resident in her last year. After that, she held a couple of faculty positions at Washington and Oregon before coming back here and helping us with the program. And I'll let you.
That's pretty accurate. Yes, it was where I did residency was Current Medical Center in Bakersfield, California, which is a UCLA affiliate. If you guys aren't familiar with Bakersfield, that's a good thing. And but it was a lot of good training, a lot of very high-risk patients. I was chief resident my last year. Afterwards, I went on to practice for 7 years privately in Vancouver, Washington, where I taught University of Washington medical students as well as WSU medical students when they started their medical school. I also helped start an internal medicine residency in Vancouver, Washington, for which I was given the privilege of being the Diversity, Equity, Inclusion, and Social Determinants of Health core faculty. What a title. So obviously some of my background, first generation Iranian American, my parents are immigrants, grew up in a very politically active family, protesting on Dixon Street when I was 5 years old in front of the old post office against the Iranian regime. I have found an old newspaper clipping from the Northwest Arkansas Times. I don't know if that still exists. I have a picture of me in the Times when I was 5. Well, now we know with the riots and all the political upheaval in Iran that maybe my parents weren't wrong 30 years ago. So, anyways, I came here and started with UAMS, Northwest Internal Medicine Residency, in August of this year. So decided to move back home. I have a 5-year-old, and that was a large reason why. And hopefully we will continue to grow and prosper and do good things in the community, and hopefully these residents become good doctors one day, right?
Hopefully. You can tell her name is Dr. Awesome, and Dr. Wright wanted me to say it's awesome that she's here with us.
He told me to also say, he's sorry he can't make it. He actually went to a friend's funeral, so that's why he's not here today.
And Leonard, you want to do a little background yourself? They know me already, so.
Well, hi, I'm Leonard Ferdman. I'm originally from Los Angeles, California. I did my undergrad studies in Wisconsin at a small little liberal arts school. And I went to medical school at New York Institute of Technology, but plot twist here is actually in the Jonesboro, Arkansas campus. So New York, but in Arkansas. And I really love the outdoors, and I really like mountain biking as well. And so this place was really perfect for me, and I ranked this place number 1 and was fortunate enough to land my residency here. So I'm interested in pursuing primary care and rheumatology when I'm older. So.
Alrighty, well, let's go ahead and get started on our topic for the day, coronary artery disease. For those of you that come to our clinic, you probably know that this is something we talk about as far as, medications that you're on, as far as blood pressure, cholesterol medicines, all the labs that we do is try and maintain heart health. And so we're going to talk a little bit about that today. a little bit of our outline. So we're going to talk about the definition of coronary artery disease. We're going to go into the epidemiology. We're going to go into the effects of aging on your heart. So not necessarily what coronary artery disease does, but what aging does, and then how coronary artery disease can play a role in your heart health as well.
I'm going to intervene. Mo's dad is a cardiologist, so you can feel free to ask him all the questions you want.
Well,
Put Mo on the spot a little bit. I like to have a little humor.
I don't know about that.
We got you, Mo.
We'll talk about the presentation of coronary artery disease. We'll talk about acute coronary syndrome just a little bit. We'll talk about chronic coronary artery disease, and then we'll talk about treatment as well.
Alrighty, so I'll start us off here. So the heart's function essentially is to provide blood to the rest of the body. But in doing so, it's also providing blood to itself. And those particular arteries where the heart provides the blood to itself are called the coronary arteries. In coronary heart disease, essentially, the heart cannot effectively bring enough blood to itself. Now, we understand this to be caused by cholesterol building up and forming plaques and blocking off the actual blood moving towards the heart. So the prevalence of CAD, or coronary artery disease, excuse me, increases progressively with age, especially 80% occurring in men and women over the age of 80. Now, particularly those over 65 account for 71% of the hospitalizations that occur with coronary artery disease. 50% of percutaneous and surgical coronary revascularization procedures occur in those over 65, and those are just big fancy ways of saying heart stents and cardiac bypass surgery as well. 60% of the defibrillator implants occur in those that are over 65 years old, and 71% of arterial endarterectomies, or removal of whatever is causing the blockage, occur in those over 65, and 82% of pacemaker implants are placed in people over the age of 65 with coronary artery disease. So we won't go over every single percent here, but this is just to show you an appreciation for, as age ranges go up, the prevalence of coronary artery disease goes up as well. We see this particularly most occurring in men, but after the age of 80, we can see that there's a slight bump in the female population. So, out of nearly 801,000 deaths in the U.S. from coronary artery disease in 2013, 81% of those deaths occurred in those over 65, but more importantly, 65% of those occurred in those over 75. So we can see that there's that difference between those between the ages of 65 and 75. Now, mortality or death rates are higher in men in general than they are in women. Women account for over 50% of those particular deaths of CAD in those in over 65. And importantly, one demographic that is particularly at risk is the African American population. So, as we age, the cardiovascular system and the heart start to not necessarily deteriorate, but change over time. Now, there are a lot of age effects that occur with cardiovascular health. First thing that happens is increase in arterial stiffness. What this essentially means is you are starting to harden the arteries. Now, what does that mean? Well, you have an increase in something called afterload and systolic blood pressure. And what that really means is the top number gets higher. Now, why does this happen? Well, you have an increased pressure that the heart has to pump against. The next thing that happens is you have a decrease in myocardial relaxation and compliance. And what this means is that the heart muscle itself no longer is able to actually relax and be calm during that phase of a heartbeat. You also have a decrease in compliance, which is another way of saying how much that heart muscle and the heart arteries can actually stretch. And that eventually leads to something called diastolic heart failure, or heart failure that occurs during the resting phase of the heart while the heart is filling with blood. We also have an increased risk for atrial fibrillation, which is an irregular heartbeat. We also have an impaired ability of the heart to respond to its own chemical stimulants like epinephrine, or we better know it as adrenaline. Now, that causes you to have a decrease in the ability of the heart to actually spit out blood and push it forward. The next thing that happens with age is we have a decrease in the sinus node function and the AV nodes function. Now, what this really means is the ability of our natural pacemaker in our hearts, the SA node and the AV node, to properly function. Over time, when this happens, we have an increase of things like sick sinus syndrome, AV block, left anterior fascicular block, and bundle branch blocks. And all of these are, again, big fancy ways in medical jargon of saying irregular heart rate or irregular heart rhythm due to a problem with the actual heart electrical conducting system. Next thing that happens that I wanted to talk about was impaired endothelial dependent vasodilation. What this means is the inability or the problems that occur with the actual lining of arteries' ability to flow. Now, that's a bunch of words. What this really means is the arteries themselves are lined with cells themselves. Now, these cells will release all these different chemicals that will regulate arteries to open and to close. And over time, when these cells don't appropriately work, you have something that develops called demand ischemia. This is a very important concept in cardiovascular disease. Demand ischemia is essentially demand, which is the need for something, and the word ischemia, which means a lack of something. So here, we are lacking appropriate amount of blood flow due to needing a higher demand of it. This overall increases your risk for coronary artery disease. Now, the next thing I wanted to talk about was baroreceptor responsiveness. Baroreceptors, another big word, we got a lot of those coming up, is basically receptors that respond to pressure. So in our aortic arch, where that large vessel comes out of the heart, and in our carotid sinuses here in our necks, we have something called baroreceptors. These are in charge of regulating blood pressure and keeping the brain active and knowing what is actually occurring with our blood pressure. Over time, this will increase your risk of something called orthostatic hypotension, falls, and fainting. Now, if you've ever experienced standing up too quickly, getting very dizzy, and feeling like you're going to faint, you have experienced orthostatic hypotension. The last and final age effect I want to talk about is a decrease to exercise response. Overall, your exercise capacity goes down over time, and this eventually is due to issues with coronary artery disease. So, typically, as we age, the heart still continues to work, but its function can start to decrease. Now, I want you to think about somebody who's 100 years old. If you know of anyone who's 100 years old, I want you to take a look at them and appreciate the fact that their heart has been pumping for 100 years, for a whole century. So over time, that function goes down, but the heart is truly an incredible organ. So the next time you see someone who's at least 100, appreciate the fact that they've been pumping for 100 years.
Yeah. One thing I'll add on to that is the fact that when we're sitting here right now, there isn't a huge change between how our heart pumped, in our 30s or 40s to right now, at rest with us sitting. But when we get up and start to move around, start to exercise, there's a big drop-off in how well our heart works, the efficiency of how it works. And that's kind of the big change that we see with aging.
Alrighty, let's talk about some risk factors. So, major risk factors in coronary artery disease: high blood pressure, diabetes, dyslipidemia, or essentially high cholesterol and issues with other lipids in the blood, and smoking. So, the increase in the top number is the strongest risk factor for including cardiovascular disease in older adults. This particularly is occurring in those over 80 years old. Now, there are guidelines that we have that are really great at kind of giving an idea of what your risk is, right? So you have high blood pressure, right? So what does that mean, right? So we have something called the ASCVD score. Now, what all this does is it tells you in a 10-year window what is your risk of developing some type of cardiovascular accident. And typically, when you have over 10%, that's kind of when you start thinking about, hey, we need to start really trying to address some of those preventable risk factors that you have. This is especially important when you're over the age of 75. Diabetes itself is an incredibly important disease when we're thinking about cardiovascular health. Everybody thinks that that diabetes is a disease of sugar, which it is, but more importantly, diabetes is a disease of arterial walls. Over time, those arterial walls won't work as great if diabetes isn't under control. Now, the Framingham Heart Study showed that there's an excess risk associated with diabetes that's greater in adults over 65 compared to those who are younger. Now, in dyslipidemia, or problems with good and bad cholesterol, if you have a low HDL, or good cholesterol, which is defined as less than 40 on labs or less than 50 in men or in women, and total cholesterol to good cholesterol ratios that are not appropriate, these are both associated with increase in coronary artery disease events in adults up to 85 years old. Now, clinical trials have demonstrated the benefits of statin therapy in moderate and high-risk patients up to those of 85 years old. And if anyone's ever wondered why they've ever been put on a statin, if anyone ever has, that's why. Because we look at those numbers, we look at the ratio of those numbers, and we determine based on age or other comorbidities whether that statin is appropriate. Now, prevalence declines with age in terms of the risk for smoking. Overall, as we age, the effects of smoking really have a predominant effect. And we typically see this because when we go to the doctor and we get counseled on smoking and we either stop smoking or decrease smoking, we'll typically have less people smoking more as they get older, as we've seen that typically smoking is related and associated with cardiovascular disease. There still remains strong and independent risk factors for smoking in terms of its effect on cardiovascular disease, especially in those in older adults. And stopping smoking has a great significant findings to show reductions in decreasing your overall risk for mortality in cardiovascular disease. Some other risk factors are obesity, low physical activity, pre-frailty, and frailty, only because the lack of bone strength isn't necessarily itself a risk factor. However, when you start increasing how frail you may be, you start being less active, you start wanting to exercise less, the risk of exercising becomes more dangerous, so overall, movement decreases, and that blood flow would decrease as well. One finding that's been showing to be extremely important in the past 2 decades has been the coronary artery calcium score, which shows how much calcium is building up in those coronary arteries, which gives you a sense of how at risk you are for coronary artery disease.
Alrighty, so how does this present? Oftentimes you aren't going to feel a thing. This is something that kind of builds up over time with unhealthy habits, and the problem when you start to experience symptoms is when it starts to become a problem. It starts to develop into what we call acute coronary syndrome, where you have a lot of blockage that prevents a lot of blood from going through, which the heart needs. Or you have an acute blockage where it's stopping blood flow to the rest of the heart muscles. So what are acute coronary syndromes? Well, there are 3 main ones that we look at, and this primarily will be in a hospital. This won't be in clinic when we see you guys, unless we're initially concerned about chest pain, shortness of breath, and things like that. The first 2, unstable angina and non-ST elevation MI, those are kind of hard to differentiate from one another because you need blood work in order to tell which one is which. But oftentimes you're going to have these symptoms at rest. You're going to have chest pain at rest, you're going to feel short of breath all the time, and that's kind of a little hint like, oh, maybe I need to go to the hospital, like an ED, and get worked up. And then ST elevation MI is an emergency. It's pretty much a complete block where that either has to be removed surgically or a new vessel has to be put into the heart so that we can recover that heart muscle. Oh, there we go. So what you see with people who get older is that usually you hear, oh, I have chest pain that's going to my left arm. That's how, a heart attack would present. But that's not necessarily the case as we get older. And it's actually, as we get after the age of 80, you start to notice it's not so much chest pain, but it's shortness of breath or inability to walk as far as we used to. So those are some of the things that we look at when we see you in clinic and have to weigh the risks and benefits of whether this is truly a cardiac event. Like I said, shortness of breath is the most common symptom you'll see. And older individuals will often present with, altered mental status or passing out, dizziness, confusion. And sometimes, not recognizing these early enough can prevent us acting on it quickly and, can really result in risky cardiac events that negatively impact your health. And of course, when these symptoms develop, it's kind of, like I said, the hint that we need to send you to the hospital so that we can work this up, so we can figure out what's going on and how we can best help you. This again, I want to focus more on the exertional fatigue. So you'll probably notice, if you're 40 years old, you could probably walk further than you can now, which is normal. That happens. Our muscles, they lose muscle fibers. But if you notice 6 months, you can't walk as far, you get really short of breath, that might be an indicator of, maybe there's something going on with my heart. And then with older individuals, you start to see that when you work this up and you find disease in the arteries, it's more severe than you would find in another younger individual. So 3-vessel disease is very severe. Disease in the main artery, the left main artery, is also very dangerous. That's kind of your widowmaker if that gets blocked off. So how do we treat this? Well, I like to think of medicine as a team game. I can tell you what to do, but it's not going to work very well if we don't work together. So there are medical and non-medical ways to or medicine and non-medicine ways to help treat this. So we'll first focus on the non-medical therapy. What does that mean? If you're smoking, stop smoking. No need to be smoking anymore. There was never a reason to smoke in the first place. You want to eat a low saturated fat diet and a low cholesterol diet. Now, there are healthy fats that you should, continue to eat, but you want to avoid the fried foods. Things with high saturated fats, you want to avoid that. You want to have aerobic exercise. So if you're a bodybuilder, that's great. Keep doing it. That's good for your balance, strength. But we also want you walking or doing something aerobic for at least 30 minutes a day. That's really going to help your heart in the long run. And then if you're overweight, we ask for a modest weight loss. We're not going to tell you, go lose 100 pounds. That's unrealistic. But if we say maybe, 10 pounds in a couple months, we make small steps that way. Now, what can we do medicine-wise? First thing I'll mention is aspirin. Aspirin affects the platelets, which can affect clots being formed. We'll never put you on a full dose aspirin because that can affect your stomach, but a baby aspirin, 81 milligrams, might be a good idea to try. If you can't tolerate aspirin, you can take what's called Plavix or clopidogrel. It's kind of an alternate medicine. Both of them affect the platelets, though, and it thins your blood. Next thing will be an ACE inhibitor, like lisinopril. These can not only affect your blood pressure, but they actually reduce mortality from cardiac events. Especially, up to the age of 85. You definitely notice that. And you'll see that we say up to 85. It's really because the studies don't go past that. Yeah.
There's not enough people to pull that data from.
Yeah.
The average age of mortality in the U.S. for women, this is pre-COVID, was around 79 or 80, and men 78. That's the U.S. statistics. So you guys are doing good, but I think the longest living people, South Korea, I want to say, and then Japan. But anyways, there's not enough data or studies over 85.
And then you'll definitely notice that we'll start you on an ACE inhibitor if you have diabetes, because it can actually help your kidneys or prevent progression of kidney disease and diabetes or other comorbidities that can increase your risk for coronary artery disease.
The common names are, they don't know what an ACE is.
Oh, I said like Cinepril earlier, enalapril. You know, it ends in april. That's probably it's probably an ACE inhibitor. Now the big one that Dr. Wright really wanted me to focus on, he actually calls it a wonder drug, is a statin. Now this is going to directly go after that cholesterol, trying to reduce the bad cholesterol that's, in our bodies. Now, what you see with statin therapy is it can raise the good cholesterol, decrease the bad cholesterol, which will decrease your chances of progressing any coronary artery disease that you'll have. And I think an important thing to note is that every medication has side effects, and if you have muscle pain with statins, there are other medications that we can try, like fibrates or ezetimibe or other medications we can try other than a statin. But typically a statin is what we will start with if we're worried about the bad cholesterol being too high.
And those other medications have not been proven to have a mortality benefit.
Yeah. Now, these medications I'm going to bring up are typically used after you have a cardiac event, like beta blockers. What those do is that they decrease the heart rate, or how often the heart squeezes. And if you have really bad coronary artery disease, the more your heart squeezes, the more the heart muscles are going to demand oxygen, and the worse the muscle will be because it can't get it. So beta blockers actually have a mortality benefit for people who have interventions for an acute coronary syndrome. Another example, calcium channel blockers, pretty similar, but they work on something different. You can see calcium channel blocking. If you can't tolerate a beta blocker, you're probably going to be started on this if you've had a heart attack in the past. Long-acting nitrates, they typically help with kind of the same thing, anti-ischemic, preventing the heart from not having enough oxygen, but they don't work quite as well as a beta blocker or a calcium channel blocker, so it's typically reserved for later. And then ranolazine is another thing that reduces the chest pain that you have and increases exercise tolerance. So like we mentioned earlier, with normal aging, the heart can't tolerate as much exercise. We'll use this medication for someone who, may have had an MI that needs not only relief from pain, but also needs to be able to exercise more.
Or someone with multivessel disease that is non-amenable to intervention, someone that can't have a cath, someone that can't have surgery.
Yeah.
Or someone that has diffuse microischemic disease, meaning the vessels are too small to put a stent in or do any surgery on, but you got pain. So this is pain relief. Doesn't prolong your life. It's only pain relief. That's really what you can think of it as. Ranolazine.
And one thing to mention with the small vessel disease versus the large vessel disease, men are more likely to have the large vessel disease, but women are more likely to have what we call microvascular disease, or those really small ones where you can't quite intervene in. All right, now let's say we've done all of these things, and we're still having problems with exercise tolerance, chest pain, or something like that. Then it might be time for a procedure. Typically, two different type of procedures you can choose is stent placement, where they go in through vasculature in your leg, go up to your heart and place a stent, or they take a vein from somewhere in your body and they place pretty much a new vessel to move blood into your heart. This can actually reduce mortality in certain patients with really risky coronary disease, or if they have, ischemic cardiomyopathy, which is you've dealt with not getting enough blood flow for such a long time to your heart that the heart has altered in its shape and doesn't quite have the normal muscle that you would have. That's what cardiomyopathy is, pretty much. So for people under 70, this is actually shown to decrease mortality by, there wasn't a number, 10% according to the Stitches trial. Now you'll note that it says under 70. Like I mentioned earlier, there were fewer older patients in the study, unfortunately. But there's also a reason why they don't pursue coronary artery bypass surgery is because of the risk associated. Like I said, medications have risk, procedures have risk. You probably have all heard this. And the risks definitely increase as we get older. Alrighty, so going into those risks, the complications of having these procedures actually increase, especially among people over the age of 80. But despite this, any doctor that you see are going to weigh the risk and benefits. If you need revascularization and it's not going to be it's going to benefit you more than it's going to be risky for you, then it's probably a good idea to get it done. And that's something that we would do, or it's not us. I guess your cardiologist will do. Not me. But they will do when they're advising you as far as what the next step is. But I think the main point of this slide is that there are risks and benefits to getting these procedures done, and those risks especially increase, especially in patients over the age of 80. Yes.
Did you guys read the Courage trial at all? Okay.
At one point.
So the Courage trial showed that in asymptomatic patients without symptoms of heart disease, no chest pain, going and looking for blockages and stenting them does not prolong your life. No mortality benefit. So there was a while where cardiologists in Florida and Arizona were bank rolling, stenting everybody, making tons of money. But out of that came all this data that showed this whole population that didn't even have symptoms that we were just doing. Patients would walk in and say, "Hey doc, I want to know if I have heart disease. Check me out. Do you have symptoms? No, still check me out." They'd get checked out. They'd find a blockage. They'd stent it. Those patients didn't live longer than they would naturally anyway. So just think about that too. The symptoms matter.
And so what you will see is that short-term mortality is high. It's much higher than stenting short-term mortality in coronary bypass surgery is much higher than for stents. But when you look past the short-term mortality, long-term mortality, coronary bypass surgery is actually shown to have a decreased mortality versus putting a stent in there. So you can imagine it's more of a permanent therapy, if you will, placing a whole new vessel in your heart versus just opening up the artery in a select spot. If that makes sense. And if it doesn't, just ask. I can maybe explain that better. Now, we kind of talked about the risks, that there are risks, but what are the risks? You will see that after doing bypass surgery, where you have to do something called ECMO, which helps move the blood for your heart when you're getting this procedure done, it is not uncommon for there to be some kind of cognitive impairment. You're going to notice that your family member may not be quite in their normal state of mind. Now, while that's not permanent, it usually recovers in 3 to 6 months. It's still a risk of surgery. Functional decline is also something that you will note after surgery. It is very important, especially after heart surgery, that you have a structured cardiac rehab program. And that is something that they'll have you do so you can slowly work your way back to where you were before the surgery. But it's extremely important that that gets done. All right. That's a lot of information. Here's a little summary slide. Aging is associated with extensive changes to the cardiovascular system, which basically results in decreases to the reserve capacity. So what that means, like we mentioned before, is that our heart at rest can probably work just fine as we get older. But as we start to become more active as we get older, you will notice that you cannot do as much as you did beforehand. And then you will see that there are significant differences in how coronary artery disease or acute coronary syndrome presents in younger people versus older people. Like I mentioned, for younger people, it's chest pain. They'll notice chest pain that goes to the left arm, maybe up to their neck. However, for older people, it is due to shortness of breath, feeling more fatigued after you do a normal amount of exercise, or what you would feel would be a normal amount of exercise. Older individuals are make up for a lot of what we see in coronary artery disease and acute coronary syndrome, which basically says why it is so important for us to get ahead of the game. Maybe start with some lifestyle changes, start with maybe a couple medications, aspirin, a statin, to try and prevent acute coronary syndrome from happening. Mention initial treatments, like I just mentioned, lifestyle changes, a low saturated fat diet, a low carb diet, aerobic exercises, 30 minutes a day, and then of course the aspirin, the ACE inhibitors like lisinopril or a statin. And then although the benefits for acute coronary syndrome or treatments are relatively similar for younger and older people, older patients are at increased risk of major complications. Like we mentioned before, it's more risky to get those procedures done. But if you need it and the benefits are there compared to the risks, it's something that definitely should be done. Okay.
So I agree with Dr. Wright. Statins are a wonder drug. I know they cause pain. Nobody likes them, this, that, the other. But before we had statins, the 30-day mortality post-MI, so you have a heart attack, and then you have another heart attack that kills you within 30 days, was really high. Do you guys know how statins work or why they prevent plaque rupture?
Yeah,
I'm quizzing them now.
So statins. People sometimes have a misconception that statins remove all the plaque that forms in the artery walls, and this is not true. Statins essentially prevent further accumulation of those plaques. So those plaques that you have that caused that heart attack in the first place are metabolically active. In other words, more plaque can start sticking to them and growing and growing. But what statins do is they prevent those plaques from building up. So those plaques that are already on those coronary arteries harden, and they're no longer going to build anymore. So it's a preventative drug. The damage is done from essentially, whatever food that you ate over time or whatever your lifestyle habits were that caused the plaque to be there in the first place. That can't really be undone, but it can be further prevented from having more build to it and eventually cause that blockage.
The statins prevent plaque progression. They are also anti-inflammatory in the blood vessel. We'll get to your question. I see a question in the back. They're anti-inflammatory in the blood vessels. So when you have a plaque inside of your vessel, you may not even feel it. You probably won't. You won't even know it. That plaque can rupture at any time, particularly if it's a soft plaque and it hasn't hardened. When it ruptures, we have this whole clotting cascade that happens inside of our blood vessels. Just like if you get a cut on your hand and you get a clotting cascade and your body says, okay, I'm going to stop bleeding. I'm going to send some proteins there that stops the bleeding. Same thing happens inside of our heart vessel. When a when a plaque ruptures, there's a clotting cascade that happens, and our body's mechanism to try to heal that ruptured lining on that plaque causes us to form a blood clot in our own vessel. So our body's process to heal ourselves then causes a major heart attack when we block it off with the clot that we formed in our own vessel. So that is why statins are important to stabilize that plaque. They stabilize the thin cap on top of that plaque from rupturing, and that is why the aspirin is important, because then aspirin stops platelets, which is the first step in that clotting cascade, so that clot doesn't form in that vessel. And this is a continuous process that happens in our vessels, and it's not all lifestyle and this and that. Coronary artery disease is a normal process of aging. We're all going to get it at some point. Whether it's symptomatic or causes us to die, that we don't know, but we all will get it at some point. So take your statin if you can.
So atorvastatin, rosuvastatin, simvastatin, those are the first three.
Those are the main ones. Lipitor, Crestor, Zocor. The main ones that have been proven to have mortality benefits are atorvastatin and rosuvastatin, also called Lipitor and Crestor. That stopped, yes. Because not everybody needs it so baby aspirin is needed for primary prevention. So what is primary prevention versus secondary prevention? You guys know? So primary prevention is I'm trying to prevent that disease from happening. For example, you don't have coronary artery disease. We don't know that you have it. You don't have any symptoms for us to work you up. We're trying to prevent that disease from happening. Aspirin is not needed in that case. But if you have, for secondary prevention, meaning we know you have heart disease, there's a blockage, you've had a prior stent, we know you got heart disease, aspirin is 100% needed in those cases. Why we don't use it for primary prevention anymore, especially over the age of 75, it's been shown to have an increased risk of bleeding and stroke and other problems. So really we want to tailor it to the population group that needs it, and those are people who have known disease or the diabetic that's under 75 that has an increased ASCVD score greater than 10% because you're so high risk. So baby aspirin for prevention is no longer needed for primary prevention, but you have to distinguish, do I have the disease or do I not? Hope that helps. Next. Statins are very, very rarely memory issues, you said, right? Very, very rarely linked to memory problems. It is on the differential for any geriatrician. If someone comes in with memory issues, they stop the statin, they see what happens. But in my practice and geriatricians I've spoken to that have been practicing for decades, it's rarely the cause. So there is some link if your HDL, your LDL, which is the bad cholesterol, it gets way too low. We're talking 10, 20. There's a link there, but we don't usually dose it high enough for it to get that low. Overall, they're not really the cause of memory issues. It's so rare.
I would also argue that with that in mind, like what you're talking about with memory changes, right? Over time, if enough plaque builds up in the brain, in those vessels, over time something called vascular dementia can form, where essentially you're not getting enough blood flow to the brain, and that can actually lead to long-term like neurocognitive problems like memory loss and dementia. So I would actually argue against that for sure. Now, can I prove it statistically? Not necessarily from a study that looked at that, but I would say that people who do have risk factors and have elevated lipids are at risk for developing that, for sure.
Vascular dementia is way more common than memory issues linked to statins, way more common. You've got Alzheimer's dementia, then vascular dementias, and Parkinson's. Those are really the most common ones. And it's a bad one. People progress very fast. So yeah, it's pretty common, especially if you've had mini strokes in the past, TIAs as we call them. Accumulation of TIAs over time will lead to vascular dementia, even though you may have never had a major stroke. So the treatment for vascular dementia is trying to prevent the risk factors and put you on an aspirin and a statin. So back to the aspirin and statin we go. No studies have shown that. So yeah, people have cholesterol, HDLs of 100 to 120. I've routinely seen that.
If you have too much good cholesterol, please teach us how you do that.
Other than the glass of red wine at night? For some people, it's genetic. It's really hard to get it to the 100 level otherwise, unless it is the red wine. Exercise will do it, but won't usually raise it that high. Yeah. With that said, an HDL under 40 is an independent risk factor for coronary artery disease. So you can have an LDL of 70, which is good, but your HDL is under 40, you're still at elevated risk. That is why when we calculate something called the ASCVD score, we put in the good and the bad cholesterol and your blood pressure and your age and your smoking all into that score.
So I mentioned something, and they don't have as much, as many studies that show their benefit as statins do, but fibrates.
Oh. The question was, if someone is intolerant of statin, what alternatives are there?
So there's fibrates, phenofibrates. There are ezetimibe, which is a little bit more expensive, but It does a good job as far as controlling your triglycerides, which is another thing we look at when we're looking at cholesterol. There's omega-3 fish,
Data's not there on that. So really, the Zetia, the fenofibrate, that's what we use. The Zetia would be the next step if we're doing primary prevention. Secondary prevention, you have known disease, you're intolerant of the statin, you're going to the cardiologist, and we're using Praluent or one of these PKS, I can't ever say it, 9 inhibitors.
PCSK9.
That's why I need them.
And that drug is called, so if you've ever heard of somebody taking like a shot for their cholesterol, that drug is actually very interesting. Its brand name is called Repatha, and the actual drug itself is called evolocumab. It's actually an antibody medicine that's been shown to have some really interesting results. But that's usually, one, is a very, very expensive medicine that sometimes isn't practical for everyone to use. And that medicine is a lot of the times used for people who have a familial cholesterol problem. So they have a genetic disease that causes them to have super high cholesterol at a very young age, like in the teens and in the 20s. I have seen it used in some people who are like in their 40s and 50s who failed practically every single other medicine, but it took a long time of them failing those medicines to actually get that medicine. There's other medicines also called bempedoic acid, I know is used a lot, in some people who are allergic to statins. But typically, if you're intolerant of a statin the first time you get it, usually a different statin will be used, and then a third statin will be used. I believe after like a third one, if you fail it at that point, you wouldn't really use statins continuously. And also it depends on your reaction, right? My dad, for example, takes statins, and he gets cramps in his legs sometimes. And he said, you know what? I've already had a heart attack. I'd rather deal with the cramps. So it also depends on, what your reaction is to the statins, and what you're willing to deal with, if it's minor or if it's major. The only one big downside to statin therapy is that you can't have grapefruit juice, and that's the worst.
Niacin can increase HDL. It causes flushing. It has no mortality benefit. Neither does omega-3s. The ones that over the counter have no mortality benefit. The prescription one has can help, especially for high triglycerides, but over the counter omega-3s don't help. Yeah, the gemfibrozil, fenofibrates, Zetia, ezetimibe, no mortality benefit either. Statins are the only one that are stabilizing that plaque from rupturing. It's not about the cholesterol numbers, it's about stabilizing that plaque from rupturing. And the data actually shows, for those that are intolerant of statins, it's because they were started at too high of a dose, and we increased the dose too quickly. So take a person, if they're not too high risk, take them off for a month, start at a very, very low dose, and progress to the dose that you want to get over several months, and that's the better approach. Different statins are metabolized differently. They go through different liver enzymes to metabolize. So if you're intolerant of one, that doesn't mean you'll be intolerant of the other one. As far as the injectables, in the Northwest, we were routinely using them up in the Portland, Vancouver area for anybody with familial hyperlipidemia, meaning a genetic cause for high cholesterol. But anybody that's had a heart attack that they took the 3 different statins and they couldn't tolerate it, then the cardiologist was prescribing those and insurance was covering them. But so the other options are either expensive, hard to get, and they don't really prevent another occurrence. Sorry. If someone comes up with a second option to statins that have the same statistics to decrease mortality, that person's going to be a millionaire. So
That's a good question. So let's say you get a referral to somebody. What does that mean? Right? So, isn't that, yeah. So what does that mean, right? Somebody says you need to see the cardiologist, and particularly the interventional cardiologist. Given that he didn't send you to the emergency room, not immediately life-threatening, which is good. Essentially, if you're being sent to an interventional cardiologist, they do a lot of things that are related to the heart, but keep in mind, the cardiovascular system is vast. It's not just the heart, it's perfusion to the legs, to the arms, to the brain. And when we talk about perfusion of blood to the brain, we're talking about the arteries in the neck, like you mentioned. So one common cause of strokes is a plaque buildup of the carotid arteries. Now, I don't know the exact statistics of how many strokes are linked to that. Dr. Assam might know.
You don't need to know that for your boards. You do need to know the percentage at which intervention occurs. All right, let's hear it.
It's at 70%. So essentially,
If.
But essentially, if there is a big enough blockage occurring in the carotid arteries, then they would send you over to the interventional cardiologist to see if you qualify for essentially having surgery there, removing that blockage, allowing that blood flow to move better through there.
Or a vascular surgeon. If they're an interventional cardiologist, then they must have also done extra training in peripheral vascular disease too. It's who? Oh, I don't know the names here yet. You may know.
But all it means essentially is that there's enough, if you're being sent to the interventional cardiologist, regardless of what it is for, it is because they are concerned that your symptoms or you are at risk for some kind of event that could be catastrophic to your health.
Let me ask you, did he have an ultrasound beforehand of your neck? Okay, so the ultrasound, if we notice that the ultrasound, the plaque progression is reaching a certain point on ultrasound, then we go for a kind of CAT scan called a CT angio of the head and neck. It is a better CAT scan that uses contrast where we can see those vessels better. And if it is 70% blocked and you've had stroke-like symptoms on that side that correspond with the blockage on that side, then intervention such as stenting here is recommended. Not really stenting as much anymore. Now they clean it out. The carotid endarterectomy. You may have seen people have a scar down their neck like this. They rotor-rooter it out there. If you have no symptoms, you have not had stroke-like symptoms that correspond with a significant plaque on that side, then you need to have an 80% blockage before it's recommended to intervene. 80%. Why? Because the risk of intervening causes a stroke. Imagine cleaning out the artery there, little parts of it break off, and then boom, you got a major stroke just from the intervention. So risk benefit, again, is important. Now, once you hit 100%, that's called a chronic total occlusion. We can't do anything about that. The other side is going to feed your brain. So we got to catch it at that 80 to 90% threshold, which is hard to do sometimes. Again, statin and aspirin really do prevent that plaque progression and stopping smoking as soon as you can. Always back to the statin and aspirin. What? I'm like a broken record over here.
Go ahead.
Mm-hmm. 5 days a week, sorry, not 7 days.
As tolerated.
Well, I like to make them really healthy. No, I believe as long as you're doing aerobic exercise, you don't necessarily need to exert yourself so much where your heart's beating 150 times a minute. But as long as you're doing aerobic exercise, that's decreasing your risk of an acute coronary event. Just moving, yeah. Walking, if you can bike, you can. Swimming is a great one. If you feel a tightness in your chest while you do that, let us know. Mm-hmm.
That is when we make sure that there's no other blockage. Sometimes you can get an in-stent occlusion. You've had a stent. Inside the stent, it occludes. We got to go put another stent within a stent. Or you got to have bypass or something else. If that is occurring, we still need to know. If we make sure that there is no significant blockage, then we put you on symptomatic treatment. the ranolazine, the isosorbide. There are meds that we use, or the beta blockers, to decrease your symptoms as long as we know there's not another significant lesion.
And in particular, when you were talking about how much exercise or what's too much or what's too little, the American Heart Association recommends 150 minutes of light to moderate activity that can be split up in any way you want. Most people just do 5 days of 30 minutes a day. Oftentimes, some people will say, if I feel like I'm exercising too much and I feel frail and I feel like I'm doing too much, well, overall, if you start getting sweat in your eye and it hurts, perhaps you are doing too much.
Another thing they say is, it's aerobic when you can talk to the person next to you, if there was somebody, but you can't sing. You're out of breath enough. I've seen that on the AHA website. I can talk, but I can't sing.
Go ahead. So I know what you're referring to. So are you referring to the Bill Gates study that came out a couple months ago? Yeah, so there were a couple studies that came out the past few years. I'm only familiar with two of them, the one by Bill Gates and the other one that I can't remember. But one of those studies that was talking about alcohol was not necessarily looking at health per se. It was more looking at behavior of men who drank. And it was talking about how over 70% of all violent things that occur that involve alcohol occur with men specifically who drink excessively. And that, in a sense, has a negative effect on men's, or I should say, drinking long term in younger populations. The other study was talking about how there was no mortality relief in those who drank excessively. And I believe the excessive amount was defined as greater than 21 drinks per week. Typically, we say that for men, over 14 drinks a week is excessive, and over 7 drinks in females per week is excessive, or 1 drink per day for females and 2 drinks per week, or 2 drinks per day for men. Okay. I do not believe that any amount of alcohol is healthy in any way at all, but there is a lot of data that suggests, especially in foreign countries like in France, where they have a very low risk of heart disease, and it is associated with the fact that they drink wine. Now, I think Dr. Assam can.
So red wine in the past was linked to an increase in your HDL. It does increase your HDL, which is your good cholesterol. And from that, it was extrapolated that it can be of heart benefit. With that said, they did further studies that said the amount needed to have that is too much for you. You cause dementia, you're going to fall, you're going to break your hip, something else is going to happen. So if you can stick with that one glass, it's okay. But remember what one glass is. When we took our driving exam, it's like, less than 4 ounces of alcohol. So, yeah, that's probably what it does increase your HDL a little bit.
I think we can maybe sneak in one more question here before we're out of here.
That's where I got to go? Where's Southwest France? Is that like Bordeaux area? I don't really know. I just know grapes are grown over there. Oh, God. One day I'll pay off my student loans and get to travel when I'm 80.
I think that is from minds much more capable and intelligent than myself.
I mean, it's exciting. I mean, when we look at transplant now with any organ, there's so many hoops you have to jump through. You know, you think of liver or lung, you know. I've heard a pulmonologist say that if you are, you know, above 70, you're probably not going to get a new liver or a new lung. So I think, you know, supply is a big component to that.
Not only that, I mean, like for heart transplant, I've had a patient that was on the transplant list at University of Washington. You can't have end organ disease from diabetes. So if you've had diabetes and you got retinopathy, neuropathy, or kidney problems, you automatically disqualify for the heart transplant. So we don't want to put it in somebody that's maybe not taking care of their diabetes and that it's wasted on. I think the future of medicine is interesting. I envision like 3D printed hearts and all sorts of weird things happening. But what does that mean, though, for everybody? Okay, we put a new heart in you. Like, let's think like space-age people. We put a new heart in you, but you can't walk. Is it worth it? So we really got to fine-tune who we're going to put this in. You may be able to walk, but you have no quality of life. So we really have to look. We can't, you know, make you live forever at the expense of your quality of life. So that always has to be looked at. The 3D printing is very interesting. I did see some stuff about that.
So it is extremely important. Okay, so the question is, what do we think about the blood pressure range for older individuals? Should it be a little bit higher based off some of the things we talked about, artery stiffness and whatnot? I will argue that it can be a little bit higher if you have no other, you know, like no diabetes or other, you know,
Haven't had a heart attack.
comorbidities. Yeah.
You don't have known cardiomyopathy. You don't have congestive heart failure. You don't have known heart disease. Up to 150 over 90 is okay. Yes. So, but you don't have any other problems. You know, that's really what it comes down to. Because the data shows lower blood pressure in your age range is linked with mortality. Definitely too low blood pressure or us trying to aggressively treat it. We overtreat, you have side effects, you pass out, you hit your head, you bleed, break your hip, get pneumonia, laying in the hospital with a broken hip, the list goes on. So too strict a blood pressure management is not great in the geriatric population, barring that there's no underlying disease.
And that is why you'll see in clinic, you know, when we're talking about blood pressure, if your blood pressure is consistently high, then we will treat. But oftentimes you guys will bring a blood pressure log and I'll tell you that your blood pressure is high at this point, but it goes down to like 110 over 70. But that 110 over 70 is enough for me to say, I don't know if I want to start a blood pressure medicine, because if it gets lower than that, it's more dangerous.
And your blood pressure becomes very variable as you age too, up and down, up and down, up and down. So
I have not, but
no, I haven't heard of that. If I was to theorize, though, I would think that it probably is decreasing like the inflammatory effect if you don't have like recurrent illness. Viruses can cause congestive heart failure in a 27-year-old. You can knock out the heart in a 27-year-old with a virus. Viruses are crazy. They take over your immune system. They do all sorts of things. They're pretty scary. I don't like to think about it personally. I don't like to think about it, but certainly I guess I could theorize that. I haven't read it though.
I'm sorry. We were supposed to get out of here at 3. If you have a question, you can
But we
come
could
up
go
and
all
ask
day.
us.
It's so much fun.
They're kicking us out. They're pretty strict about it today. But if you got questions, come up and ask and we'll answer.